So what about the MRI versus ultrasound? Of course, ultrasound or transvaginal ultrasound remain the first-line tool for ectopic pregnancy, but the accuracy is limited only to 20 to 40% preoperatively because it's operator-dependent, firstly, and also bowel gases and oligohydramnios may suboptimal the study, and also the difficulty to distinguish the abdominal ectopic pregnancy from other ectopic type. So MRI the best, of course, because for multiplanar capability and a large field of view and excess of tissue resolution and lack of ionization radiations. So what to take home message from these cases? Of course, abdominal ectopic pregnancy is defined as ectopic pregnancy that occur in the peritoneal cavity mainly, and it represents about 1% of the ectopic pregnancy, with only form of the ectopic pregnancy that can lead to the full-term healthy baby, but of course it carries very high risk maternal and fetal morbidity and mortality. And it's considered as obstetric emergency. So what's the role of the radiologist here before termination to guide radiologically the position of the fetus, the position of the placenta, the feeding artery for placenta, and if there is any complication or infiltration by placenta. And also through high index of the suspicion and thorough clinical ultrasound examinations are crucial to diagnosis abdominal pregnancy, and also transvaginal ultrasound is considered to be the first tool line for diagnosis, the abdominal ectopic pregnancy, and also standardization for the treatment, preoperative and postoperative, would improve the newborn survival, reduce the complications, and also the mortality. These are the reference. Don't rush to the next chapters. Don't keep flipping page. This moment is why your life is happening. Be here. This is written by our colleague Raif. And thank you.
Can we scan the QR code?
Assalamu alaikum. I'm resident Mayar Mahmoud. I will present about trauma in disguise, the diagnostic challenge of blunt bowel injury under the supervision of Dr. May Wahid and Dr. Ala Zahr. Our case is 40-year-old male patient came to the ER after a car accident, blunt trauma, no penetrating trauma at all. Fast scan was done and was positive for minimal free fluid. So CT triphasic was requested. This video is axial cuts of the CT. We can see in this area free air with no lumen surrounding it. In these two axial cuts, we can see nearby bowel loops thickening in the wall and enhancing, with nearby stranding and haziness in the mesentery. In these two coronal cuts, we can see the air-filled collection after tracing the bowel. This patient was actually vitally unstable, requiring immediate surgical intervention, and was found to have bowel perforation, and patching was done. So, what are the CT signs for blunt bowel and mesenteric injury? First, we need to know why is it important, despite the fact it's rare incidence, 1 to 5% only. As bowel injury, once present, always for surgical intervention. Unlike solid organ injury, main line of management is non-surgical. The management of blunt trauma in general, we start with FAST, which is focused assessment sonography of trauma, and it's positive when there is free fluid in any of these areas. Once the patient is stable, and according to the amount of the fluid seen in the FAST, CT would be ordered. Our direct findings for blunt bowel and mesenteric injury are discontinuous bowel wall, which is considered the most specific sign, yet it's not sensitive, as not all patients of trauma will have oral contrast. Free air, 95% specific, yet not always indicating bowel injury, as there is other causes as diaphragmatic injury or chest tube placement. Also, it's important to know that the location of the free air will guide us to know the site of the perforation, As the second to fourth portion of the duodenum, ascending colon and descending colon are retroperitoneal. Other structures as first part of the duodenum, jejunum, ileum, cecum, transverse colon, and sigmoid, and upper part of the rectum are intraperitoneal. Our indirect findings of blunt bowel injury: abnormal bowel wall enhancement, as we saw in our case. Hyper-enhancement in the bowel means bowel ischemia. We also have something called Janus sign, which is alternating enhancing and non-enhancing areas. As we see here, the yellow arrow for enhancing, red arrow for non-enhancing. Focal bowel wall thickening, we also saw it in our case, reaching 3 to 4 millimeter. It's an important sign, yet easily missed since we have different phases in the peristalsis. Free fluid. Not all types of free fluid are the same. It's important to comment about the amount and the mean attenuation, which is the density of the fluid. In this picture, we can see the seatbelt sign, which is radiological and clinical finding, ecchymosis in the site of the seatbelt, and this helps us to guide us at the site of the injury. Mesenteric infiltration and extravasation. Extravasation of contrast material is more specific and generally requires surgical intervention. Mesenteric infiltration in the form of hematoma or contusion, seen by stranding and hazy appearance, and increased attenuation in the mesentery. We have other associated findings in patients with blunt bowel and mesenteric injury: multiple abdominal visceral injuries, usually with solid organ injuries, higher risk for bowel injury. Pancreatic injuries, it's associated with duodenal injury and vice versa. Chance fracture, also known as seatbelt sign, which is considered a grave sign, where spine tears apart in a horizontal fracture into upper and lower part, usually associated with multiple injuries. Our take-home message is: any trauma patient with positive FAST, according to the amount of the FAST and the stability of the patient, CT scan should be done. In CT, we should check for mesentery and bowel injury, not only solid organ injury, as it's always for surgical intervention. Thank you.
ببدأ يا نورهان ولا ما؟ لا هو مش موجود.
Good afternoon. My name is Myrna Mahmoud. I'm a second year resident in Ain Shams University Hospital at Dimadash. Today I have an interesting body case about hepatic artery pseudoaneurysm under the supervision of Dr. Omar Tahoun and Professor Dr. Assam Hafiz. Okay, so we have a 31-year-old female patient. She was medically free with known history of both cholecystectomy CVD injury. So she underwent correction using hepatojejunostomy and biliary stent placement. The patient started, after this procedure, started to experience abdominal pain, jaundice, melena, and a severe hemoglobin drop, and was presented with shock. So an urgent FAST was requested. The FAST showed moderate turbid free pelvic abdominal fluid. So the patient was stabilized in the ICU, and CT mesenteric angiography was requested. So these are the photos of the CT mesenteric angio. We have the three phases: arterial, portovenous, and delayed. The first phase, the delayed, shows the pseudoaneurysm coming from the right branch of the hepatic artery. We're going to skip to the third photo, which is the delayed phase. It shows the jejunum containing contrast, although the patient didn't take any oral contrast. And the middle photo shows the biliary stent in the jejunum. That's the coronal view. Again, in the first photo, we can see the pseudoaneurysm. The second photo, we can see the biliary stent. And the third photo, we can see the contrast in the jejunum. That's a more clear image of the pseudoaneurysm from the anterior branch of the right hepatic artery. So that concludes that there is actually an hepatic artery pseudoaneurysm complicated with contrast extravasation into the jejunal loop, suggestive of fistula formation. So that explains the severe hemoglobin drop the patient was experiencing. She was bleeding into her bowel. The surgery department consulted our interventional radiology unit, and the decision was super selective embolization of that pseudoaneurysm. So that's the diagnostic angiography. The first photo shows the catheter in the common hepatic artery. While the second photo, the arrow pointing to the normal hepatic blush, the normal left hepatic artery. That photo shows the arrow pointing to the pseudoaneurysm or the bleeder site, which was a small branch, so it can be sacrificed. These are the post-embolization photo. We can see that the whole branch, anterior branch of the right hepatic artery is closed. That's because during the procedure, as a common complication, there was a flux of the embolic material and non-target embolization of the whole anterior branch of right hepatic artery occurred. That's the post-embolization CT mesenteric angiography. We can see that the pseudoaneurysm has completely disappeared, and we can see there is hyperdense areas of the embolic agent. And in the third photo, we can see the hypodense areas as a result of the infarction, post-embolization. That's the coronal view. Again, we can see that the pseudoaneurysm has completely disappeared, and we can see areas of infarction. Okay, so these are the findings. So the options for endovascular intervention, according to the Society of Interventional Radiology, glue embolization, which was used in this patient, is reserved for small arteries, which can be easily sacrificed, like in this case, while a covered stent graft is gold standard to preserve hepatic arterial flow, especially in larger arteries. In this patient, glue was the first option because it was a small branch of the right hepatic artery, although there were complications, but it was the first option. And although the patient developed areas of infarcts and transient elevation of hepatic enzymes, her general condition completely improved, and her hemoglobin level went from 4 to 11, nearly normal levels, and she was completely discharged from the ICU and from the hospital in a stable condition. So it was life-saving. The take-home message, hepatic pseudoaneurysm is a rare but rather fatal complication following valvular intervention. What is a pseudoaneurysm? It is a contained arterial rupture. Blood escapes into a sac connected to the main artery. Causes may include, it can be iatrogenic, as in this case following valvular intervention, or traumatic, blunt or penetrating liver injury, inflammation, infections such as cholecystitis and abscess, or tumor invasion. Clinical presentation, it can be completely asymptomatic, or it can show symptoms such as abdominal pain, Quink's triad, which is gastrointestinal hemorrhage, like in this patient she had melena, jaundice, and biliary colic, and hemoperineum if the pseudoaneurysm ruptured. So to conclude, the investigation, CT angiography is the best non-invasive diagnostic test and initial test to guide the anatomy and guide the planning. Catheter angiography is the gold standard to confirm the diagnosis of the pseudoaneurysm and allow treatment, either by embolization or stent. These are my references. Thank you.
Good evening. My name is Mirna Ihab. I'm a second-year radiology resident. The case I'm presenting today is under the supervision of Dr. Marwa Mohammed and Professor Dr. Azam Hafiz. This is a patient, a 32-year-old female, who's presented to the ER. The patient had symptoms of abdominal pain, constipation, and symptoms generally appearing to be intestinal obstruction or superior mesenteric artery syndrome. She was giving a vague history of an abdominal surgery 5 months ago. So as an initial investigation, an X-ray was done. The X-ray showed no evidence of intestinal obstruction. A pelvic abdominal ultrasound was done, and it showed a dilated edematous small bowel loop, and it was the transition point was at the right iliac fossa. The superior mesenteric artery and superior mesenteric vein were both seen patent. The picture was suggestive of closed loop, as there were 2 ends that were occluded at the same point. A CTPA was recommended, and it showed the exact same image that we saw in the ultrasound. It was written in the report that the proximal jejunal loop was dilated and it's collapsed on both ends, and that the rest of the small bowel loops was seen collapsed. The intraoperative details showed that there was an adhesive band, it underwent adhesiolysis, and there was an evidence of a previous site-to-site anastomosis. These are both images. This was the CTPA that the patient has done, and this was an intraoperative image. And these were our reports. Retrograde information: the same patient was admitted 5 months ago. She was suspected of intestinal obstruction. The patient had a history of an obstetric surgery. She had cesarean section, followed by injury of a bowel, and then she underwent resection anastomosis. 2 days later, she had symptoms of intestinal obstruction, which was later reported as it was functional rather than mechanical. So the timeline of the patient's condition was resection anastomosis following the iatrogenic injury. 2 days later was functional SBO. 5 months later was adhesive SBO, as it was described as a closed loop, followed by another resection anastomosis. So why didn't it show up in the X-ray? In closed loop obstructions, there are 2 obstructive features. The first is the closed loop syndrome, and the second is the supralesional syndrome. The closed loop happens much more rapidly. The closed loop, there is venous stasis and extravasation, so it distends with fluid. That's why it doesn't appear in the X-ray, and it's much better seen in ultrasound. The supralesional syndrome has 2 scenarios. The first one is tympanitis and vomiting. That, given that the closed loop syndrome was not that rapid, if it was more rapid, as in that patient, she would have a flat belly, meaning that the bowel above the transition point wouldn't be dilated. So our take-home message is that X-ray alone is not a reliable tool to exclude IO. It is actually misleading in 20 to 40% of patients, and although it is stated that it's usually not appropriate by the ACR, yet in some conditions and in some patients it can have a significant value, especially in cases of SBO, and that it can have variable presentations, and all should be put in consideration. And history as well is very important to be well taken from the patients. The ACR appropriateness criteria, there are 2 variants. The first one is for the acute presentation, and the other is for the indolent. In the acute presentation, X-ray is said to be maybe appropriate, and ultrasound is usually not appropriate. In the indolent, it says that both are not appropriate. Although this is what is stated in the ACR, yet in our condition, we have seen that it was actually a valuable tool. So it is suggested that ultrasound can be used as a method for screening of intestinal obstruction. Its diagnostic criteria: there are primary diagnostic criteria. First of all is bowel loop dilatation, and it's stated to be more than 30 centimeters in small bowel loops. Altered peristalsis as hyperkinetic peristalsis in early mechanical obstruction, to and fro movement also in mechanical obstruction, decreased or absent peristalsis in advanced obstruction or complications. The third part is being fluid-filled loops. We can also stage the severity and the severity of the obstruction based on the loop diameter, the peristalsis, wall thickness, valvulic conventus, and the presence of free fluid into simple SBO, decompensated SBO, and complicated SBO. Advanced diagnostic feature would include localizing the transition point, Doppler assessment. It was found that if the resistive index was more than 0.79, it would suggest the need for surgical intervention. If it's more than 0.85, it would suggest the need of resection anastomosis. Wall thickness assessment, if it's more than 3 millimeter, and differentiation of mechanical versus functional obstruction. So there's a suggested algorithm of how this case should be managed. If there's an index of clinical suspicion, we should proceed for ultrasound first. If it's positive for intestinal obstruction, we should then proceed to contrast-enhanced CT, since surgeons wouldn't operate only on ultrasound. They would need a document from a CT to operate upon. If it's negative for intestinal obstruction, then the surgeon would re-examine the patient or conserve the patient. If there is still strong index of suspicion, then we should proceed for contrast-enhanced CT. If not, then the patient would not go through any further investigations. And in cases of SBO diagnosis, a recent meta-analysis has found that the ultrasound has overall sensitivity of 92% and specificity of 93%, given that the radiologist is well trained on it. Thank you.
هو في هنا بوينت.
انا بس عايزه point. البوينتر مش باين هنا، مش بيتحرك، محتاجه البوينتر.
محتاجين نكليك بس.
عاصم هو ده كمان.
لا سوري. طب ما هو بيتحرك اهو خلاص.
لا البوينتر مش شغال.
عايزين ماوس. هو فين عايزين الماوس.
عايزه البوينتر.
مش بس لو في فيديو هيعطل منك
لا،
عشان
مفيش
كده.
فيديو.
طيب ماشي.
Okay, good afternoon. I'm Isra Ashraf, a radiology resident at Ain Shams University Hospital. I'll be presenting a neuro case that had unfortunate outcome. This case is under supervision of Dr. Rana Mohsen. She's a 21-year-old female presented with disturbed conscious level after a tragic road traffic accident. Here is the initial CT scan was done. We can appreciate multiple fractures implicating the right posterior wall of the orbit and the left temporal bone and the left mastoid bone. Moreover, there are different types of hemorrhages. As we can see, there is hemorrhagic contusion, subarachnoid hemorrhage, and hematoma. On initial CT, of course, we notice multiple fractures and area of hemorrhage, but apart from these dramatic findings, there is something much more subtle yet extremely important. Anything catching your attention? Do you see something unusual here? At first glance, it might look normal, but focus your eyes here. We observe asymmetry between the two sides of the cavernous sinus. 1 week later, another CT brain was done, demonstrating contour bulge on the left side of the cavernous sinus and prominent superior ophthalmic vein. In a trauma patient, if you notice cavernous sinus fullness and dilated ipsilateral superior ophthalmic vein, what important diagnosis must we suspect? We should consider cavernous venous fistula. Here we started to see the signs of secondary changes that happens due to congestion that includes preseptal and postseptal edema and edematous extraocular muscle. So the secondary changes that happens due to congestion consist of congested dilated superior ophthalmic vein, retrobulbar fat stranding or edema, and the edematous extraocular muscles. Moving on to MRI. Here's the clear sequence. Left cavernous sinus is seen enlarged by the virtue of multiple signal void vascular channels. And here we can see prominent superior ophthalmic vein. In situ coronal image, we can appreciate contour bulge on the left side of the cavernous sinus. And finally, here is the angiography. The angiogram illustrated early opacification of the cavernous sinus in the arterial phase, together with arterialization of the superior ophthalmic vein. CT was done 1 month later, revealing intraocular hemorrhage. Sadly, this subtle diagnosis was missed initially, and the patient condition progressed until she lost her eye. So what is the cavernous sinus anatomy? Cavernous sinus is a pair of venous structures that is located on the either side of the cella and the body of the sphenoid bone. They are small, yet they are incredibly rich structures, enclosing cranial nerves and the intracavernous portion of the internal carotid artery. Cavernous venous fistula usually develop with clusters of symptoms, starting with the ocular findings that include chemosis and subconjunctival hemorrhage, and also orbital findings like pulsatile exophthalmos that happens because of transmission of the blood in the arterial pressure into the cavernous sinus and its tributaries that results in pulsatile exophthalmos, and also ophthalmoplegia that occurs due to cranial nerves involvement and eventually progressive visual loss. There are two types of cavernous venous fistula. Direct type, like in our case today, that it is direct communication between the intracavernous internal carotid artery and the cavernous sinus. And indirect type, where there's communication between the branches of the carotid circulation and the cavernous sinus. The modality of choice, the non-invasive modality of choice is CT angiography that shows us the features that we have tackled before. So the take-home message, it's pretty easy to miss a pathology in this region. And the consequences could be devastating to the patient. Although non-contrast CT brain has limited sensitivity to pick up a pathology in this region, but we should pay attention to the contour and the caliber of the cavernous sinus, because one glance at the cavernous sinus might save an eye. Okay, thank you.
Good evening, dear professors and colleagues. I am Dalia Tariq, radiology resident at Ain Shams University Hospitals, class 2021. I'll present a nuclear medicine case today under supervision of Dr. Iman Sharif and Professor Dr. Minna Had. A 42-year-old female patient with history of right eye blindness. She has past history of bronchial asthma with no history of oral contraceptive pills intake and not any other medication. CT chest was ordered with no significant finding were noted. And on the septal tissue window between D9 and 10, this lesion was noted. So incidentally found left neural exit foraminal hypodense dumbbell-shaped lesion causing vertebral body scalloping. So what is the differential diagnosis? The differential diagnosis include the schwannoma, the meningioma, and the paraganglioma. As regards the schwannoma, they are benign tumors of Schwann cell origin and the most common tumor of peripheral nerves, including cranial nerves. Presentation depends on the location of the tumor, but generally symptoms are due to local mass effect or dysfunction of the nerves they arise from. CT is not as sensitive or specific for diagnosis of schwannoma, as we can just see the adjacent bone remodeling. So we can notice the rim of marginal sclerosis, and for foraminal remodeling, the CT image on the left, and the MRI image on the right, there is expansile soft tissue lesion expanding into the intervertebral foramen. As regards the meningiomas, they arise from the covering of the spinal cord. They are one of the most common intradural extramedullary spinal tumors. The imaging findings include the dural tail sign, which is extradural mass with dural tail extending above and below, as seen with the yellow arrows. Usually located posterolaterally, compared to a nerve sheath tumor, which is typically located anteriorly. Neural exit foraminal winding is less commonly seen with meningioma rather than with nerve sheath tumors. As regards the paraganglioma, they are uncommon neuroendocrine tumor arising from the paraganglia and principally encountered in adults. Usually seen as well-circumscribed mass, and with post-contrast MRI shows the typical avid arterial enhancement of paraganglia with the characteristic salt and pepper appearance as seen with the yellow arrow. So our case was winding the neural exit foramen and the corticated edges is likely consistent with the schwannoma. So PET CT scan was ordered, so we could notice the metabolically active precaval, right paratracheal, and subcarinal lymph nodes. And irregular subcapsular hepatic dome hypodense mildly active focal lesion seen at segment 7. We could notice the decrease in SUV max in the delayed images, achieving SUV max of 11.46 in the early images and 10.65 in delayed images, which in favor of benign conditions. As regard the dumbbell-shaped lesion, showed mild activity, achieving SUV max of 2.62. So complementary MRI was done, showing ill-defined focal lesion, exhibiting high signal in STIR, low signal in T1, with minimal true diffusion restriction, and no detected post-contrast enhancement. So could represent focal hepatitis or edematous changes, show in favor in benign conditions as we expected by the delayed PET CT images. So our teaching point, the schwannoma are benign tumors of Schwann cell origin, and they are the most common tumor of peripheral nerves. PET CT scan is negative for detection of nerve sheath tumors. And the dual time images of PET CT tracer uptake is effective in exclusion of malignant lesion, as we see in the previously mentioned hepatic focal lesion. Our references. And the nice words by Dr. Raif.